chronic kidney disease, CKD. My name's Georgia and I'm one of the junior doctors at SWBH Trust. These are the learning outcomes for the presentation, which are aligned to your university curriculum. Now, we're not going to be going over dialysis or the renal manifestations of systemic disease purely for the purpose of time, so make sure you do this elsewhere. Now, as I'm sure you're aware, kidney function is measured using GFR, so glomerular filtration rate. The GFR ranges from 0 to 90, and most young, healthy individuals would have a GFR of 90. Now, in chronic kidney disease, there is a chronic reduction in the GFR that is typically irreversible. It's diagnosed either when their eGFR is less than 60 for 3 months, or when the GFR is more than 60 but there's evidence of kidney damage, again for 3 months. Now, when we talk about kidney damage here, we're talking about proteinuria, hematuria, evidence of abnormal anatomy, or systemic disease. So CKD is a common condition, and 8.5% of the adult UK population have stages 3 to 5. The prevalence is also increasing because of an ageing population and also because of the increasing prevalence of comorbidities such as obesity and diabetes mellitus. Now, in reference to why an ageing population is causing an increasing prevalence, this is because renal function naturally reduces with age. Now, there's not always an identifiable cause for this besides age itself, but some say that polypharmacy and also increasing comorbidities are contributory factors. Now, aside from increasing age, there's also a number of other risk factors for the development of CKD. With ethnicity here, it's those that are of African, Caribbean, or Asian origin that are an increased risk. I'm sure you're all very fluent with the parts of a history, so the present and complaint, history of present and complaint, etc., etc. In a patient with CKD, or whether that's proven or suspected, you're going to go through the exact same process. However, there are a few specific things that you can elucidate that can give you things and clues about what could be going on and also what the underlying cause could be. So, with regards to the history of present and complaint, when it comes to symptoms, each kidney has more nephrons than what is needed to sustain life, and therefore extensive damage can occur before there are any obvious effects. So in terms of symptomology, patients with CKD don't necessarily become symptomatic until the latter stages of the disease, and this is typically when urea exceeds 40. So when urea is above 40, patients develop general constitutional symptoms such as diarrhea, vomiting, and anorexia. These are a result of uremic toxicity and also delayed gastric emptying. They also might have symptoms of the complications of CKD, so anemia, edema, hyperparathyroidism, and things like that. We'll cover these later on in the presentation. When the urea is greater than 60, there tends to be CNS involvement, and therefore patients may have confusion, myoclonic twitching, encephalopathy, fits, and if left untreated, go into a coma. Pain is an uncommon symptom in CKD itself, but if it's present and dependent on the location and the nature, it could be suggestive of urinary outflow obstruction or infection anywhere in the renal tract. It's also important to ask specifically about urine and what it looks like. So frothy urine can suggest proteinuria, pink or red urine could be hematuria, and then dark urine could symbolise dehydration, or indeed myoglobinuria if there's been rhabdomyolysis, and also hemoglobinuria if there's been hemolysis. Also, if there's frank blood, if it's in a young person, it could suggest IgA glomerulonephritis, and if it's in an old person, it's cancer until proven otherwise. Then, depending on the timing of this frank blood, so if it's at the start of the stream, it could be urethral bleeding. If it's at the end, from the bladder or prostate, and if it's throughout the entire stream, then it's likely glomerular bleeding. You're also going to be asking about frequency, so how many times someone's urinating. If it's reduced, it could be dehydration or sepsis, and if it's increased, particularly at night, it tends to symbolise prostatic enlargement or infection. You're also going to be asking about the volume of urine produced. Now, if it's polyuria, so if it's increased, then there's a defect in the urine concentrating system, or it could be that there's been excess water ingestion. If there's anuria, so a decrease in the total volume of urine, if this is absolute, then there's either urethral or bilateral ureteric obstruction, progressive glomerulonephritis, or aortic or bilateral renal artery occlusion. It's also important that you establish the duration and progression of symptoms, again because this helps to elucidate the underlying pathophysiology. What you want to be doing as well is asking specifically about recent infection. Now, this could signify the use of antibiotics, some of which, such as aminoglycosides, can actually be nephrotoxic. But also, if it was specifically in the urinary tract, particularly if it was in the upper urinary tract, or if it's recurrent, it could signify abnormal anatomy, but also these things in themselves can increase the risk of CKD development. And then also you're going to be asking about throat infections, particularly streptococcal infections, because of the increased risk of post-infectious glomerulonephritis. Moving on to past medical history and any comorbidities that can increase the risk of CKD, but also could be a complication of CKD itself. Then family history, so particularly renal disease such as polycystic kidney disease, which is hereditary. And then drug history focusing on nephrotoxins. And finally, a systems review to help you identify any undiagnosed comorbidities, which again could either be as a result of the CKD itself or could increase the risk of developing CKD. Moving on to examination, so first of all looking at the hands, pallor could suggest anemia. You're looking at skin turgor to assess fluid status, and then a flapping tremor could suggest uremia, so a build-up of those uremic toxins. You're then going to look at the arms, particularly looking for a fistula. Now this can be radiocephalic, brachiocephalic, or brachiobasilic. You're going to look for signs of recent use because that will indicate the stage. Recent use could be indicated by needle marks or dressings. Then looking at the neck, so using the JVP to assess the fluid status, and then moving on to the eyes. So corneal arcus and xanthelasma can both occur in nephrotic syndrome due to the hyperlipidemia, and then you can get pale conjunctiva in the anemia. And then looking at the tongue again to assess for fluid status and signs of dehydration. Moving on to the chest, listening to the heart sounds, there might be a gallop rhythm, which in older patients can often suggest congestive heart failure. There could be mitral regurgitation, which is common in polycystic kidney disease, and there also could be pericardial rub, which can indicate uremic pericarditis, which is actually quite common in patients with renal failure, so it occurs in 5 to 10%. You're also going to be listening to the lung bases to assess for evidence of pulmonary edema, and also feeling and assessing for sacral edema because of the fluid status. Moving on to the abdomen, obviously you need to make sure you've got a chaperone and a consenting patient for this. You're going to be looking for scars, so nephrectomy scars in the flank and transplant scars in the groin. You're also going to be blotting the kidneys to assess for their size and shape. You're going to be percussing for a distended bladder, and you're also going to be listening for renal bruits, which are apparent in renal artery stenosis. Then finally, you're going to be looking at the legs, again assessing the fluid status by looking for a peripheral edema. Now, throughout the examination, you should also be looking for signs of confusion and also systemic disease. There are also a few things you need to consider in addition to this. So blood pressure to assess for hypertension, but also orthostatic hypotension, which can be caused by renal failure itself, but also conditions relevant to CKD, such as diabetes, cardiovascular disease, and amyloidosis. Now, depending on the clinical suspicion, you might also perform a digital rectal exam to assess for the size of the prostate, and also fundoscopy to assess for diabetic or hypertensive retinopathy. Now, in terms of diagnosis, you need to essentially test for 3 things. So serum creatinine and then derive the EGFR, early morning urine to measure the albumin-creatinine ratio, which measures proteinuria, and then also a urine dipstick for hematuria, because that in itself can suggest more concerning underlying disease, such as cancer. Now, the flowchart shows what to do and how to act on it, but the key thing here is that the changes need to be present for at least 3 months. If after 3 months the GFR and the ACR are both normal, so they're not meeting the criteria for the diagnosis of CKD, then you need to repeat the test annually, just because you've identified these patients at being at higher risk of developing CKD. Just a few things to bear in mind about GFR. So patients should not eat meat within the 12 hours before the test, and also you need to account for ethnicity, gender and muscle mass, just because they can all affect the urea and the creatinine. So this table shows the CKD classification and staging based on GFR and ACR. Don't worry too much about learning it all off by heart, but certainly understand how the GFR changes between each stage. The green and red colour coding signifies the risk of adverse outcomes as a result of the CKD. So as we've already discussed, diagnosis is based purely on the GFR or the ACR, but there are also other investigations that should be performed to establish 1. The underlying cause of the CKD, 2. The severity of the CKD, and 3. Whether there are any complications because of the CKD. So when it comes to bloods, you're going to do a routine haematology and biochemistry panel. Now, obviously the changes in the urea and creatinine are part of the CKD itself, but a lot of the other changes that you see might be a result of the complications of CKD. We'll talk about these later on in the presentation. Then, depending on your clinical suspicion, you might also go on to decide some other blood tests. So if there is hyperlipidemia or hypoalbuminemia, it could be suggestive of nephrotic syndrome. Then you might also do protein in urine electrophoresis. So if they're positive for monoclonal antibodies and free light immunoglobulin light chains, so Bence-Jones proteins respectively, they may suggest multiple myeloma, which can affect the kidneys. Then if there's anti-neutrophil cytoplasm antibodies, it could be vasculitis, and if there's anti-glomerular basement membrane antibodies, it could be Goodpasture's or SLE. You're also going to perform urine analysis, so both a dipstick and also send it off for further analysis. So certain characteristics and the presence of certain things can signify the underlying cause. Now, I'm not going to go into this for the purpose of time, but do read around it at a later stage. Now, imaging. There are lots of modalities of imaging, but first point of call is invariably an ultrasound of the renal tract. Now, dependent on the findings of this and also the clinical suspicion, you may then go on to perform a CT-KUB. Now, preferably this would be with contrast in order to assess for filling defects. However, with that comes the risk of nephrotoxicity, and unfortunately those with CKD might not necessarily have the sufficient remaining function left to tolerate the contrast. So in the case like this, you need to be thinking carefully about the risks and benefits, and if you do decide to go ahead with it, then you need to also make sure you're thinking about pre- and post-contrast renal therapy. Now, those with CKD typically have lower bone density than the general population, so therefore you might consider performing a DEXA scan to stratify the risk of fractures in the future and also the need for replacement therapy. Then, depending on the suspicion of underlying cause, you might go on to perform a renal biopsy. So screening should be offered to those at an increased risk of developing CKD, such as those listed here. It's important to bear in mind that you should never use obesity in the absence of metabolic syndrome, so diabetes, or age, gender, or ethnicity as risk factors alone for screening, because it's not cost effective. So as we've discussed, in CKD, the reduction in renal function is often irreversible, so management is fundamentally aimed at preventing any further progression. What you want to be doing is preventing the need for dialysis and renal transplantation later down the line. So this requires regular monitoring in order to assess for and manage the complications and risk factors for the progression. In those with CKD stage 3A or less, this should be done if there's clinical suspicion of any of these being present. But then with those with stage 3B or more, it should be done routinely, typically every 6 to 12 months. Now, these are some of the tests you might perform, but it's not an exhaustive list and you'll need to use your clinical judgment. Now, those with CKD are at an increased risk of cardiovascular disease, and patients with CKD are 20 times more likely to die from cardiovascular disease than progress to end renal disease. So, the pathophysiology of cardiovascular disease in CKD is different to that in the general population. In the general population, there is obviously the atheroma formation, but in CKD, there tends to be vascular calcification and also LVH dysfunction. So therefore, what you need to do is reduce the risk of cardiovascular disease, and this can be via means of statins, so atorvastatin, and the dose is dependent on the absence or presence of comorbidities, and then also antiplatelets, but you only give antiplatelets as secondary prevention, so to those with coexisting cardiovascular disease. In addition to this, you're also going to be thinking about immunisations due to the reduced immunity of patients in CKD, and also simple lifestyle modifications that can in fact have a big difference. So, as any practitioner involved in a patient care, you need to be able to recognise and also manage the progression of CKD. There are risk factors for the progression, and these risk factors can be risk factors for both gradual and also accelerated progression. So the non-modifiable ones are age, gender, and then the modifiable ones are hypertension, smoking, systemic inflammation, diabetes, and AKI. There are also proven compounding effects of these risk factors in combination with each other. So this is the definition of progression of CKD, and then there's also accelerated progression. Now, in the presence of any type of progression, you need to investigate for an underlying cause, and then you also need to be optimising the management of these underlying causes and try to correct or reverse them. So NICE guidelines stipulate that as a non-renal specialist, you should consider referring to renal medicine if a patient meets any of these criteria. Don't worry about learning these off by heart, but certainly have an appreciation of them because they help you to identify the markers and signs of poorly controlled CKD. So moving on to the common complications of CKD, of which there are many. So anemia in CKD is multifactorial. Erythropoietin, EPO, is produced by the peritubular interstitial fibroblasts in the kidney. In CKD, these cells undergo transdifferentiation, so reprogramming into myofibroblasts, which causes them to lose the ability to produce EPO. Therefore, less EPO is produced in response to hypoxic stimuli, meaning that the bone marrow is signalled to produce red blood cells to a lesser extent, resulting in anemia. There's also the chronic uremia present in CKD, which shortens the life of the red blood cell. Then you've got hepcidin, which is made and secreted by the liver. Now, it regulates iron metabolism by binding to ferroportin, the iron export channel, and prevents the iron from entering the hepatic portal system. When hepcidin is raised due to inflammation, for example, which is commonly present in CKD, serum iron levels will reduce. And then finally, you've got iron. So there's an absolute iron deficiency due to malnutrition and poor absorption in CKD. All of these three factors combined contribute to anemia. Now, the Kidney Disease Organisation and NICE have different thresholds for anemia, but this is a rough guide. So moving on to the management, patients with CKD stage 3 should be tested for anemia at least annually, and those with stage 4 to 5 more frequently. It's really important that the anemia is treated in order to reduce symptoms, but also reduce the risk of the cardiovascular effects it has. So if there is any iron deficiency, then you need to replace it with supplements. These can be given either orally, but are often poorly absorbed, so therefore can be given intravenously. So the dose of intravenous replacement is determined by the degree of deficiency and also weight. Now, when you're replacing iron, it's important that the ferritin levels don't exceed 800. Then, if the hemoglobin levels are around 11, you might consider either ESA, so erythropoietin stimulating agent, or exogenous EPO in order to kind of improve the anemia. then where possible, what you need to be doing is avoiding blood transfusion in those where kidney transplant is a treatment option, just because of the risk of developing antibodies. What you're aiming for is a target HB of 10 to 12. So starting with secondary hyperparathyroidism. In CKD, the reduced GFR results in high phosphate due to a reduced renal excretion. The high phosphate then causes a low calcium. The 4 parathyroid glands, which are situated in the thyroid, secrete PTH in response to the low calcium in the blood. So, i.e., you get secondary hyperparathyroidism. The PTH acts to increase calcium by increasing absorption in the kidney, increasing resorption, so reducing the amount excreted in the kidneys, and then also increasing osteoclast activity in the bone, so breaking down the bone. Additionally, there is vitamin D, which acts on all 3 organs alongside PTH to increase the absorption of calcium. However, both CKD and the raised phosphate levels individually reduce the synthesis of 1,2,5-hydroxyvitamin D, which further reduces the calcium levels. The lack of vitamin D, for the reasons described, reduces bone formation. And then the reduced bone formation, alongside the increased osteoclast activity, results in mineral bone disorder. Patients with mineral bone disease will have an increased propensity for fractures, bone pain, osteopenia, and radiologically you might see lytic lesions. So how do you manage these patients? Well, you need to be advising them to have a low phosphate diet, and you might also consider phosphate binders, which reduce obviously the oral intake. You also may give calcium supplements or vitamin D analogues, or oral calcium receptor agonists such as cinacalcet. So in the early stages of CKD, there is actually a tendency for fluid depletion due to a reduced ability to concentrate urine and polyuria. However, in the later stages, there's a marked tendency for fluid retention. This is because extracellular fluid volume is determined by the balance between sodium intake and its renal excretion. In CKD, due to the reduced function of the kidneys, there is reduced sodium filtration and inappropriate suppression of tubular reabsorption. This causes expansion of the extracellular fluid volume. Now, this can manifest as edema, which is typically peripheral, abdominal distension, and fatigue, for example. If it accumulates in the lungs, which it often does due to the increased pulmonary capillary permeability, then you get pulmonary edema, which can cause shortness of breath. Due to the effect this has on gaseous exchange in the lungs, pulmonary edema can be life-threatening. Clinically, it can be quite difficult to ascertain the underlying cause of fluid overload, particularly because patients with late stages of CKD commonly have heart failure too, in what is called cardiorenal syndrome. But ultimately, what you need to try and do is get rid of the excess fluid. Now, in CKD and heart failure for that matter, this can be done using diuretics. Now, diuretics ensure diuresis by inhibiting sodium reabsorption in the different segments of the renal tubular system. So here we have the renal tubular system, and then loop diuretics such as furosemide act on the thick limb of the ascending loop of Henle. They act specifically on the sodium-potassium chloride cotransporter and subsequently increase the sodium, potassium, and chloride excretion. Then you have thiazide diuretics such as metolazone, which act on the distal convoluted tubule, specifically the sodium chloride transporter, and they increase sodium chloride excretion. In addition to this, you also need to be thinking about sodium restriction and also restricted fluid intake. So for those in acute pulmonary edema, as you would with any acutely unwell patient, you need to perform an A to E assessment. Historically, we were always taught to PODMAN everybody. So position them upright, give them targeted oxygen therapy, give them intravenous diuretics either as a bolus or infusion, give them morphine to help relieve the sensation of breathlessness, antiemetics and also nitrates. However, NICE now recommend against the use of morphine and nitrates due to their vasodilatory effect. So patients with CKD may already be on a diuretic, so you'll need to bear that in mind when you're making the decision on how much to give them, because what you need to do is make sure you're giving them a higher dose, otherwise you're not going to get rid of the fluid. Also make sure that you think about catheterization, especially in the elderly, frail and confused, because they will by design have increased frequency in polyuria, which can be difficult to manage if they're unable to get out of bed. So moving on to hypertension. Hypertension occurs in 90% of patients with CKD. It's diagnosed in patients with CKD in the exact same way as you would the general population. So either a blood pressure over 140/90 on 3 separate occasions, or over 135/95 if it's measured using a 24-hour ambulatory model. Sorry, that should say 135/85. So hypertension can either be primary, so with no identifiable cause, or secondary if it has an identifiable cause. So you should investigate a patient with CKD and hypertension in the same way you would any patient with hypertension alone. You want to be looking for an identifiable cause, so whether it's secondary, and then you also want to be looking for end organ damage and the potential complications. The issue with hypertension is that persistent hypertension in turn exacerbates the glomerular damage, further reducing the GFR, and so that creates a perpetual damaging cycle. Therefore, it's really important that the hypertension is well controlled. Unless the hypertension is severe or there's end organ damage or it's malignant, then you should try simple lifestyle modifications first before starting pharmacological therapy. So things like increasing exercise, reducing weight, and a healthy diet. But if a patient remains hypertensive despite this, you need to start antihypertensive medications. As per NICE guidelines, the target blood pressure and the pharmacological therapy used is dependent on the ACR and also the presence of diabetes. So, in non-diabetic patients, if the ACR is less than 70, then you're aiming for a target less than 140/90. Within this category, if the ACR is less than 30, you need to be treating it as per the normal hypertension algorithm. But if the ACR is more than or equal to 30, you need to use a renin-angiotensin system antagonist as first line because of their beneficial effects on proteinuria. So something like lisinopril or losartan. Now the clause is that even if the patient's non-diabetic, if they have an ACR of 70 or more, you need to be having a target of less than 130/80. And then regardless of whether they have hypertension or not, you need to start an antihypertensive. So you're going to be giving them a RAS antagonist again because of the beneficial effects of proteinuria. So in diabetic patients, however, they're going to be treated, all of them, with a RAS antagonist with a target of less than 130/80. Again, they've got a lower target because they're at higher risk of progression due to the presence of diabetes. So there are a few common medical emergencies in CKD, of which hyperkalemia is one. It's common in CKD due to the reduced potassium excretion in the kidney, but also secondary to drugs commonly used in CKD, such as ACE inhibitors and spironolactone, a potassium-sparing diuretic. Hyperkalemia can be classified as mild, moderate, and severe. Severe is a medical emergency, can be life-threatening. A patient's presentation will depend on the level of potassium, and you can get apparent cardiac arrhythmias, And this is because potassium causes hyperpolarization of the cell membranes, which reduces cardiac excitability. This can cause the patient to experience palpitations, chest pain, or syncope, and clinically, it may present as hypertension, bradycardia, ventricular fibrillation, or cardiac arrest if left untreated. Patients may also have muscle weakness and confusion, and respiratory paralysis can occur, which will ultimately result in respiratory arrest if the potassium exceeds 8.5. So how are you going to investigate these patients? So typically, any patients who are acutely unwell or deteriorating for whatever the reason is will have a VBG or ABG, just because of how quickly it enables you to identify any life-threatening abnormalities such as hyperkalemia. But it's also important that you think about taking a full set of bloods, including FBCs, USANEs, LFTs. The USANEs are often a better measure of the electrolytes than the ABG or VBG. There are also classical changes to the ECG in hyperkalemia, and specific ones occur depending on the degree of hyperkalemia. So when a potassium is 5.5 to 6.5, you tend to get tall tented T waves, a shortened QT interval, and also ST depression. When it's at 6.5 to 8, you'll get the peaked T waves, prolonged PR interval, and reduced or disappearing P waves with a widened QRS. Then when potassium exceeds 8, there's often an absence of P waves and a widening of QRS. The concern obviously is that this results in ventricular fibrillation and cardiac arrest. So management. As with any acutely unwell patient, you're going to assess them in an A to E manner. Now, patients with a potassium greater than 7 or those with a potassium greater than 6 with ECG changes require urgent treatment. Now, in the immediate term, treatment involves 30 ml of 10% calcium gluconate. Now, you only give this if there are ECG changes present. The ECG should improve within 1 to 3 minutes, but if after 5 to 10 minutes there's no improvement, you can repeat the dose. You're also going to give 10 units of Act Rapid in 50 ml of 50% glucose and 10 milligrams of salbutamol nebulizers. These all help to drive the potassium into the cells. So, if despite the treatment the patient remains hyperkalemic, you might also consider calcium resonium, sodium bicarbonate, and frusemide, but this would always be a senior-led decision. In the longer term, if the patient remains hyperkalemic with a potassium more than 7 or other significant findings such as refractory fluid overload, uremia, or acidosis, then they may need to be considered for dialysis. It's important in any patient that after the immediate stabilisation, you then go on to measure the potassium at irregular intervals to assess for the response to treatment, but also to try and establish the underlying cause and prevent recurrence. So, metabolic acidosis. The body's pH is regulated by the amount of acid, so carbon dioxide, and base, bicarbonate, in the plasma. Ventilation controls the amount of carbon dioxide, and the kidneys control the amount of bicarbonate. In a metabolic disorder, be that acidosis or alkalosis, the primary disorder affects the amount of bicarbonate. Patients with CKD commonly develop metabolic acidosis. Now, metabolic acidosis can be characterised in terms of the anion gap, which is calculated via this equation. The anion gap is essentially the difference between the amount of anions and cations in the plasma, and a normal anion gap is 6 to 16. The metabolic acidosis can be classified as a normal anion gap metabolic acidosis, where there is a loss of bicarbonate causing a compensatory rise in chloride, which can be caused by a loss of bicarbonate from the gut, such as diarrhea, but also excess sodium chloride intake, so from fluids, for example. But there can also be an increased anion gap, and this is where a new acid is introduced to the plasma, causing dissociation into hydrogen ions. What happens then is the bicarbonate ions are lost because they're trying to bind up those excess hydrogen ions. So this can be caused by things like lactic acidosis in sepsis, ketoacidosis in DKA, but also certain medications, for example, salicylate poisoning. But then also it can be caused by failure to excrete the acids due to acute or, in this case, chronic renal failure. As with hyperkalemia, patients may present with symptoms and signs, but also could be asymptomatic. They could have shortness of breath due to the increased respiratory drive in order to blow off the carbon dioxide, so the acid. They also might have nausea and vomiting or anorexia, and then they might have symptoms of the underlying cause. In terms of investigation, again, you're going to do an ABG or a VBG to establish the presence of the metabolic acidosis. You're also then going to be thinking about routine biochemistry tests to establish the type of acidosis. But also then, depending on clinical suspicion, you might send things like blood cultures if you're suspecting sepsis, or salicylate levels or alcohol levels if you're suspecting an overdose. And these will all help you diagnose the cause. So moving on to the management, again, you're going to assess them in an A to E manner in order to attempt to stabilise them. Ultimately, you need to try and treat the underlying cause of the metabolic acidosis. In those with asymptomatic chronic acidosis, such as patients with CKD, you might consider giving them daily oral bicarbonate supplements. Now, NICE suggests that this should be considered in anyone with CKD stage 4 or 5 and a bicarbonate concentration less than 20. In those with symptomatic or acute severe metabolic acidosis, intravenous sodium bicarbonate can be given. However, this should always be a senior-led decision and is often in ITU, because in the short term it can in fact worsen the acidosis by producing CO2. These patients also might go on to be considered for dialysis. Now, uremia occurs when there's a retention of substances that are normally excreted in the urine. It commonly occurs in the latter stages of CKD. Many of the retained toxins cause direct damage themselves, but also issues arise from the indirect effects that these toxins have on other processes. The effects are far-reaching and it can affect most body systems. For the purpose of time, we're not going to go to cover these now, but the symptoms and manifestations of the uremia form part of uremic syndrome. So symptomatic uremia tends to occur once creatinine clearance decreases below 10, unless kidney failure develops acutely, in which case some patients may become symptomatic at higher creatinine clearances. Patients presenting with uremia typically complain of nausea, vomiting, fatigue, anorexia, weight loss, muscle cramps, pruritus, and if the toxins cross the blood-brain barrier, they can cause changes in mental state, seizures, and ultimately coma in what's called uremic encephalopathy. In terms of management, patients who develop uremic syndrome tend to already be on dialysis, but in those that are not, or if they are symptomatic, and it can't be treated by medical optimization of the underlying cause or the manifestations, then dialysis should be initiated in an acute setting, regardless of what the EGFR is. Patients presenting with a uremic emergency, so patients that have hyperkalemia, acidosis, or symptomatic pericardial effusion or encephalopathy will require urgent dialysis regardless. So in CKD, many drugs require dose reduction or cannot be used at all due to the risk of accumulation and toxicity. It all comes down to the way in which pharmacokinetics, the movement of a drug in the body, are affected by renal disease. So if you remember, there are 4 aspects to the pharmacokinetics of a drug: bioavailability, distribution, metabolism, and elimination, all of which are affected in different ways as a result of the CKD. Some to be acutely aware of are metformin, which is contradicted if the GFR is less than 30 due to the risk of lactic acidosis, insulin, due to reduced resistance in CKD, meaning that patients might require a lesser dose of insulin, aminoglycoside antibiotics such as gentamicin, which are renally excreted, and therefore the half-life will be increased in poor renal impairment, which may mean that you need to either reduce the dose or increase the dosing interval. Then you've got antiplatelets and anticoagulants, because the presence of uremia, which is common in CKD, increases the effects of the antiplatelets and anticoagulants, resulting in an increased tendency for bleeding. You've then also got morphine, which is metabolized in the kidneys, so therefore can accumulate, meaning that patients are more vulnerable to the sedatory effects, which could ultimately cause respiratory depression. Now, this list isn't designed to be exhaustive, but if in doubt, the best place to look is either the BNF or the Renal Drug Handbook, which is really good at giving details on how to change the dosing depending on the GFR. So that brings us to the end of this presentation. I hope that you found it useful, and good luck with all your studies.